for joining us.
Oh, my favorite topic. Wouldn't miss it. How are you?
Doing well. Where are you in the world?
I'm in Zimbabwe.
Oh, you're in a better place. We're all snowed in here.
Yes, it is. Well, I mean, yes, it is such a gift to be here right now. I'm so sorry for what you all are experiencing in the US. I think of you all the time.
Good to hear you. Thank you so much for making time for the webinar.
Cheers. Yes. Thank you for putting this together.
The team did.
Yeah, terrific.
Hi, Winnie.
Hi.
Assumpta from Rwanda.
Oh, hi, Assumpta. How are you?
Hi, fine, thank you. And you?
I'm doing well. There's just too many buddies on the call, it seems.
Hi, my namesake Assumpta.
Oh, hi, Assumpta.
I will wait a minute or two, and when my team says we can go ahead, I will get started.
Okay.
Hello, this is Mukunzi from Burundi.
Good morning, Mukunzi. Welcome. So maybe I can get started. I think is it okay, Lydie and others, if I get started?
Hello.
Oui, exactement. Merci, Winnie.
Gambia.
Good morning. So we will invite everyone to introduce yourself into the chat box. You can type your name there. I will get started. Good morning, good afternoon, everyone, and thank you so much for making time to participate in today's webinar. Before we get started, we have a housekeeping slide, and I'm requesting that people follow the directions so that you can have your language of choice be selected for the interpretation. Because we do have a mix of English and French presenters. So please follow, in looking at the slide right now, you click on the globe at the bottom or right of your screen and follow the steps to select your language of choice. We will continue to project those instructions as people come join the webinar. So I'll give a couple of seconds for people to do that, and then we can get started. So I'm Dr. Winnie Mwebesa. I'm the Associate Vice President Technical within the Global Health Department at Save the Children US. And I'm excited to have the opportunity to moderate today's panel as part of the Care for the Small and Sick Newborn Community of Practice. Today's theme focuses on improving care of the inpatient care of small and sick newborns in sub-Saharan Africa. And we'll be hearing about implementation challenges, best practices, and lessons to carry forward. And we are thrilled to have three distinguished panelists joining us to share insights about implementation in their context. What I'll do is I will briefly present each of them before they present so that we can, we know who they are. And so for the first speaker, I will now welcome our first panelist who will share the Mali experience. And for this, I will shift to French to introduce and hand over to Dr. Fanta Coulibaly. Dr. Fanta Coulibaly, and so just briefly before we do that, I see that we have shared the agenda. So as you can see, the agenda will allow for each of the presenters to have 15 minutes. We will have a presentation from Mali, a presentation from Ghana, followed by a commentary from WHO Afro. And hopefully we have enough time at the end for questions and answers. And I'm sure that you will have lots of questions for them after hearing their presentations. So now I will shift over to French to introduce and hand over to Dr. Fanta Coulibaly. Dr. Fanta Coulibaly est une obstétricienne-gynécologue obstétricienne par formation avec plus de 25 ans d'expérience dans la santé maternelle, néonatale et reproductive dans le secteur public au Mali. Au cours de sa carrière, elle a tenu plusieurs postes de gestion au sein du ministère et pour le moment, elle est responsable pour la surveillance des décès maternels et périnatales ainsi que la réponse au sein de la Direction générale de la santé et de l'hygiène publique dans le ministère de la Santé au Mali. Je laisse maintenant la parole à Dr Coulibaly pour nous présenter l'expérience du Mali. Dr Coulibaly, allez-y.
Okay. D'accord. Merci beaucoup, Madame la modératrice. Donc, j'ai l'honneur aujourd'hui de vous présenter le programme national pour les soins aux nouveau-nés, petits et malades, sa mise en œuvre, ses défis et opportunités au Mali. Diapo, slide. En introduction, nous disons qu'au Mali, la mortalité néonatale reste un défi majeur. Elle est estimée à 33 pour 1000 naissances vivantes selon l'EDS, enquête démographie et de santé 6, faite en 2018. Il y a 33% des naissances qui se déroulent à domicile. Le temps d'observation après l'accouchement n'est pas respecté dans les structures de santé. La majeure partie de la période néonatale se passe chez nous à domicile et le nombre élevé de décès s'expliquerait par le retard dans le recours aux soins ou l'absence de soins appropriés. Et au Mali, seulement environ 37% des structures de santé de référence offrent des soins mères kangourous. Slide. Les différentes stratégies ont été mises en place au niveau de nos politiques pour la mise en œuvre des soins aux nouveau-nés. Il s'agit, entre autres, de la gratuité des soins qui concernent la césarienne, qui est gratuite chez nous. La prise en charge du paludisme est gratuite pour les enfants de 0 à 5 ans et pour les femmes enceintes. La vaccination est gratuite. La prise en charge du VIH est également gratuite, non seulement au niveau des nouveau-nés pour la prévention de la transmission mère-enfant, mais également au niveau des femmes et toute la population. Il y a l'existence des plans stratégiques aussi qui sont là. Il y a les plans stratégiques santé de la reproduction maternelle, néonatale, infantile, adolescent et la nutrition. Les plans stratégiques paludisme, santé communautaire et nouveau-nés qui existent. Il y a la stratégie nationale de digitalisation avec l'appui de l'UNICEF qui consiste à mettre en place un registre longitudinal de suivi des enfants au niveau des ASC dans la communauté. Nous avons également l'intégration des modules de formation. Donc, l'ensemble des modules de formation concernant le suivi de l'enfant, on est en train de les intégrer pour faire un module commun de formation qui va prendre en charge le PCM, prise en charge intégrée des maladies de l'enfant, les soins essentiels à la communauté, soins mère kangourou et le soin essentiel aux nouveau-nés et le programme HBB qui a aidé les enfants à respirer. Nous avons également comme autre stratégie l'implication des acteurs et des décideurs. Slide. Please, slide. L'état de mise en œuvre du programme. Au Mali, les santé, au niveau de l'accouchement, il y a les soins qui sont octroyés à la mère et des soins octroyés aux nouveau-nés. Pour les nouveau-nés qui nous concernent aujourd'hui, nous avons différents types de soins, à savoir les soins essentiels aux nouveau-nés appelés SEN, qui est octroyé dans les structures de santé, les soins d'urgence aux nouveau-nés dans les cadres des soins obstétricaux et néonataux d'usage, et les soins essentiels aux nouveau-nés dans la communauté SEC. Et pour les soins spécifiques aux nouveau-nés prématurés et des petits poids de naissance, nous avons les soins mère kangourou. Les soins aux nouveau-nés malades, nous avons se fait dans le cadre des programmes de prise en charge intégrée des maladies de l'enfant qui concernent les nourrissons de 0 à 2 mois, qui est notre sujet aujourd'hui, et concerne également les enfants à partir de 2 mois jusqu'à 59 mois. Nous avons le PCM communautaire aussi, qui est un programme de sensibilisation de la communauté sur l'utilisation des services de santé. Slide. Donc, les soins essentiels sont des soins immédiats qui sont donnés aux nouveau-nés et à la mère. Parmi ces soins, nous avons les soins de routine, et nous avons la mise au sein précoce, la promotion de l'allaitement maternel exclusif, l'utilisation de chlorhexidine 7,1% pour le nombril du bébé pour éviter les infections au niveau de l'ombilic et l'utilisation de tétracycline ophtalmique pour éviter les conjonctivites du nouveau-né. Nous avons également l'utilisation qui est vraiment récente de l'oxymètre de pouls pour diagnostiquer la détresse respiratoire chez les nouveau-nés. Ce programme a commencé en 2020. Par rapport à la chlorhexidine, nous remercions beaucoup le projet SSGA et Service de santé à grand impact de l'USAID qui a eu quand même à mettre en place l'utilisation de la chlorhexidine au niveau des 4 districts sanitaires lors de la phase pilote et une commune de Bamako. Et il y a eu la mise en place du comité de pilotage, l'inscription du chlorhexidine sur la liste nationale des médicaments essentiels et insérer la chlorhexidine, l'utilisation de la chlorhexidine dans les politiques, normes et procédures révisées et dans les plans du nouveau-né. Donc, et la mise à échelle a été faite également par le projet SSGI. Vraiment, cette mise à échelle a été émaillée d'un incident majeur qui est la mauvaise utilisation de la chlorhexidine par la communauté ayant entraîné la cécité chez les nouveau-nés. Donc, la recommandation a été faite de changer l'emballage de chlorhexidine car cet emballage-là avait beaucoup de similitudes avec l'emballage de tétracycline pommade ophtalmique et les gens mettaient ça sur les yeux de l'enfant au lieu du nombril et ce qui a créé des accidents. Slide. Les soins essentiels aux nouveau-nés dans la communauté et ces soins sont prodigués par les agents de santé communautaire et ça commence par la tenue d'un répertoire des femmes enceintes et nouvelles accouchées dans les villages. Et il y a des étapes de soins simples au nouveau-né qui est le maintien de la température, retard du premier bain, mise au sein précoce. Et surtout, il y a la visite à domicile où les conseils sont donnés par les ASC et les signes de danger sont recherchés et référés. Les nouveau-nés sont pesés et les petits poids de naissance sont dépistés pour être référés au niveau des structures de santé. Et la pessimie communautaire concerne les pratiques familiales favorables à la santé, l'hygiène environnementale, l'eau, hygiène, assainissement et cette activité est menée par les agents de santé communautaire et les relais également. Slide. OK. Et pour ce qui concerne les soins spécifiques aux nouveau-nés prématurés et aux petits poids de naissance qui nous intéressent aujourd'hui, nous avons ces soins sont produits à travers la recherche des signes de danger, on l'avait dit chez le nouveau-né, l'identification des petits poids de naissance et qui sont référés pour les soins mère kangourou. Et il y a eu également la création des unités mère kangourou au niveau des hôpitaux et des districts sanitaires, surtout l'hôpital CHU Gabriel Touré au niveau de Bamako. Il y a eu la formation des hôpitaux et des districts sur la gestion des petits poids de naissance. Également, il y a la remontée des données sur les petits poids de naissance prématurés qui se fait dans nos rapports mensuels d'activité. La création des services de néonatologie au niveau des hôpitaux et des CCRF également. Et dans les slides, dans le cadre du projet Service de santé à grand impact de l'USAID, il y a eu l'appui au gouvernement du Mali dans la mise en œuvre de la gestion des soins mère kangourou. Et dans ce cadre-là, SSGI a eu à former 997 prestataires à la gestion des prématurés et des petits poids de naissance et 430 sites qui offrent les services de soins mère kangourou, dont 30 CCRF et 400 CESCOM dans 3 régions du Mali, à savoir Kaye, Sigasso et Koulikoro. Et il y a eu l'inclusion de 3 indicateurs dans les systèmes d'information sanitaire, à savoir le nombre de petits poids de naissance et le nombre de petits poids de naissance initiés sur les soins mère kangourou. Il y a eu 19 287 petits poids de naissance qui ont bénéficié de soins mère kangourou entre octobre 2016 et septembre 2019. Et il y a eu la confection des 4 conseils sur les soins mère kangourou qui a été fait par le Kenya Djemuka du projet SSGI. Le projet Born on Time également œuvre également dans le domaine de la formation des prestataires pour les soins mère kangourou et la dotation de l'équipement des structures de santé SESCOM. Slide. D'accord. Pour les soins au nouveau-né malade. Les soins au nouveau-né malade se fait à travers le programme PESIME. Et ce programme PESIME, prise en charge intégrée des maladies de l'enfant, a un volet clinique. Et ce volet clinique-là, il y a un volet électronique aussi, c'est-à-dire le module clinique qui a été digitalisé. Et par rapport à la digitalisation, nous avons le registre électronique de consultation qui est utilisé dans la région de Ségou avec le partenaire Terre des Hommes. Il y a l'oxygénothérapie et soins aux nouveau-nés par l'ONG Mousso et qui a eu à faire des formations en cascade. Le projet R qui est améliorer l'insuffisance respiratoire chez les enfants de 0 à 5 mois est en train de se produire également à Djoila, dans la région de Koulikoro et à Markala. Il y a l'intégration de l'oxymètre de pouls dans l'évaluation pessimée électronique. Nous venons de dire pessimée clinique et la pessimée qui a été électronisée, digitalisée. Et il y a eu l'intégration de l'oxymètre de pouls pour le dépistage des détresse respiratoire chez les nouveau-nés qui a été prise en compte. Le logiciel i4 aussi qui prend en compte le pessimé électronique. Nous avons l'intégration des modules pessimé permettant quand même de se former sur place. Et cette plateforme existe pour la formation des prestataires de soins. Slide. Slide. D'accord. Et ce qui nous amène aux défis et perspectives. Par rapport aux défis, nous avons une grande insuffisance dans l'offre des services de soins, à savoir l'insuffisance de l'unité de néonatologie, unité de soins mère kangourou, les coins du nouveau-né au niveau des salles d'accouchement. C'est vraiment insuffisant chez nous. Seuls les projets pilotes qui ont eu à bénéficier des soins mère kangourou, et ça existe à ce niveau. Il y a l'insuffisance en équipement, à savoir les couveuses, l'oxymètre de pouls, les tables chauffantes. Nous avons également noté comme défi le coût élevé de la prise en charge des nouveau-nés, l'insuffisance du personnel qualifié. Et non seulement ce personnel est insuffisant, et il est inégalement réparti sur le plan géographique, sur l'étendue du territoire malien. Nous avons également l'insuffisance dans la collecte et l'analyse des données et l'insuffisance dans l'enregistrement des naissances à l'état civil. Par rapport aux perspectives, nous avons la gratuité de la prise en charge des nouveau-nés qui est fortement recommandée et qui est en train d'être mis en place, prévu dans la réforme de la santé. Nous avons également la formation du personnel en coaching mentorat pour vraiment une formation continue en vue d'améliorer la qualité des prestations de services. Nous proposons également des recrutements locaux du personnel qualifié pour pallier aux problèmes d'instabilité du personnel est lié à l'inégale répartition du personnel sur le territoire. Slide. En conclusion, nous disions que le gouvernement du Mali et ses partenaires, dans le cadre de la mise en œuvre de sa politique de développement humain durable, s'inscrit dans le cadre des objectifs de développement durable en mettant un accent particulier sur la réduction des décès maternels et néonataux. Ceci permet d'avoir une approche commune et convergente afin de donner plus d'efficacité et d'efficience aux différentes interventions dans les établissements sanitaires et dans la communauté pour réduire la mortalité et la morbidité maternelle et néonatale. La mise en œuvre de ces programmes permet l'amélioration de la santé de la mère et par ricochet celle du nouveau-né. Je vous remercie pour votre aimable attention.
Merci beaucoup, Dr Coulibaly, pour votre présentation et surtout aussi pour l'avoir fait dans le temps imparti. Nous avons déjà quelques questions pour vous, donc on va vous les envoyer. Lydie, si quelqu'un pouvait lui envoyer les questions qu'on a déjà, que les gens se sont déjà adressés afin qu'elle ait le temps de les préparer. Et avec ça, je vais inviter notre deuxième présentatrice et je vais maintenant commencer à parler en anglais. So thank you very much, Dr. Coulibaly, for your presentation. We already have a number of... Thank you. And so wait, merci. Hein? Wait. And I just wanted to tell participants that we are seeing your questions, so continue to post them in the chat box. We will make sure that we do our best to answer them at the end. And so thank you so much and someone on the team is going to pull them together so that I don't forget to get the panelists to answer them. And if we don't get to them, we will make sure that we have the answers compiled and shared with everyone later on. So with that, I will invite our second panelist, Dr. Adome Odame from Ghana. Dr. Adoma is the senior specialist, a pediatrician at Hope Exchange Medical Center in Ghana. She has worked with various hospitals across the country, setting up newborn units and training staff in the care for newborns. She's recognized as a national newborn health champion. Dr. Adoma, please go ahead.
Okay, thank you so much for this opportunity. So I will briefly look at care for the small and sick newborn in Ghana, and I'll look at it under the umbrella of the newborn action plan and strategy, because that has been one umbrella under which everything seems to fit in for us in Ghana. Next slide, please. So look at the national strategies, the relation to the WHO care for small and sick newborn, the challenges, and then the way forward. Next slide. All right, so the first newborn strategy and action plan came about because we realized that as a country, even though our under 5 mortalities were going down, our infant mortalities, our neonatal mortalities were still remaining pretty high. And so we were in danger of not being able to achieve the Millennium Development Goals way back then. So that's how come the first National Newborn Strategy and Action Plan came about. And its goals back then, that was from 2014 to 2018, were to contribute to the reduction in neonatal mortality from 32 per thousand to 21 per thousand by 2018. And we also wanted to reduce the institutional neonatal mortality by about 35% by 2014. The first National Newborn Strategy and Action Plan mainly focused on improving basic newborn care. So basic essential care for newborns, resuscitation training, prevention of infections for newborns, and then providing some level of necessary extra care for preterms within the country. Next slide. So a number of things went on within that period. UNICEF supported some hospital-led supervision visits in which the consultants went to the hospitals, stayed there for a length of time, taught them on the job how to be able to care for their sick newborns. So you can see the picture of mothers doing kangaroo mother care on one side, and you can see the picture of clinical staff being taught how to do an exchange blood transfusion for a baby. That is on the other side. Next slide, please. Then PATH also led in the training of healthcare workers in 4 regions in the country. We have 16 regions, then we had 10. So they led in the training of the care of the newborn for 4 regions. All healthcare workers, doctors, nurses, obstetricians, pediatricians, whoever deals with newborns was taught in helping babies breathe, essential care for every newborn, and then infection prevention. So you can see the baby doing skin to skin, even on the theater. It was pretty much unheard of before PATH taught us about it. And then with the PATH training of that MEPSI program, we also didn't just train them, but actually went and then followed them up over a period of about a year to see whether they were able to retain their skills. Next slide, please. Other things that were done during that period included the preparation of documents for kangaroo mother care. It was a training manual that was developed during that period. And as a result of that, one of the hospitals in one of the regions is a designated center of excellence. So other hospitals send their staff and continue sending their staff for training in kangaroo mother care. So that's one of the things that was done. Next slide. Then we also had newborn champions, and please go back. Newborn champions, and in newborn champions, these are people, leaders, next slide please. People who are stakeholders or important people within the community, who are teachers, maybe queen mothers, maybe chiefs, and what they do is they mobilize the community and get the community interested in care of the newborns. So some of them are, let me say, celebrities, radio presenters, TV presenters. They get the community involved in get the community interested, I should say, in the care of the newborn and in newborn issues. We also developed the newborn standards within that period, in which this is a document that teaches hospitals or teaches anybody that if you want to set up a newborn facility, you need this amount, this size of a room, you need these equipment, these are the staff that you need. And it also contains monitoring tools for the sick newborn, like temperature charts, like seizure monitoring charts, etc. Next slide. Yes, so I mentioned the newborn champions. Another thing that I should mention is that they also donate to the cause of newborns. There's one newborn champion who had actually built a facility, a facility for maternal and child health that contained a newborn unit. So those are some of the things that the newborn champions do. And in the picture, you can see two newborn champions. Both of them are queen mothers, and they were inaugurating a newborn awareness day. Next slide, please. So then, with all that, after some time, we had to review what was going on, and then we came up with a second newborn strategy and action plan. And in this second newborn strategy and action plan, you realize that we come up with some 10 strategies that are pretty much in line with the WHO standards for caring for the small and then sick newborn. Why did we come up with this new strategy? We wanted to further push down the deaths. We didn't achieve what we had targeted. So we want to push down the deaths from 25 per thousand to 18 per thousand. We also want to reduce the institutional stillbirth rates and then to contribute to the reduction of neonatal mortality institutionally by about 40% by 2023. And I should mention that Professor Indira has been very instrumental in developing this newborn strategy and action plan for our country. Next slide, please. So all of these strategies, all of the standards that WHO has come up with do fit in one way or the other to our standards, to our strategies. For instance, our first strategy has to do with strengthening leadership and governance for newborn care. And in Ghana, we have the newborn subcommittee. And this is a committee that meets regularly and they present to the Director General of the Ghana Health Service. They organize a national newborn stakeholders conference in which once a year, people from the whole country come together and then they discuss what they were able to achieve the year before, and then they have an action plan for the year ahead. And they're actually held by what they say they will do. And then we also have the newborn focal person. But some of the challenges are that there are competing interests. At the level of leadership. You know, there are answers when it comes to, COVID has now come and COVID has taken all the attention and all the finances. So there are still competing interests, and those are some of the challenges. Next slide, please. The second strategy that we have has to do with strengthening, developing, and updating policies and tools. And realize that this one ties in with the WHO standard 1 about evidence-based practices. So in Ghana, Pediatric Society has done some training on jaundice. We have the KMC documents, we have the Safe Motherhood Protocols, IPC guidelines. We use the Essential Care for Every Newborn and Helping Babies Breathe protocols, etc. But we still have challenges because the standards of care differ in the country based on where the child may be. If the child is in one of the cities, like Kumasi, like Accra, then the child may receive a higher level of care than if he's in a remote place. So that's still one challenge. And then the newborn component of these policies has to be strengthened. For instance, the IPC document, that's a document on infection prevention and control. The newborn care, what should be done in the newborn unit needs to be strengthened. Next slide, please. The third strategy that we have has to deal with improving health financing and resource mobilization. And this one ties in some way to functional referral systems, the use of ambulances. The government procured some ambulances last year, one ambulance for each district. The country is further subdivided from regions into districts. So each district has an ambulance, but then these ambulances don't have neonatal transport incubators to be able to transport the very sick and small newborn. And other challenges are that sometimes you may be ready to send the patient, you have the ambulance, but then the parent is not willing to go because the parent doesn't have the finances to foot the ambulance bill, or the parent is worried about how are they going to pay for the care on the other side. So we still have some challenges there. Next slide, please. The fourth strategy has to deal with the health information systems. And this one ties in with the WHO standard 2 of having actionable health information systems. So in Ghana, we have the DINS, which is a system, an IT system that the districts feed their data into. So the hospitals and the districts feed their data into this system, and then it goes to the national level. So that software is there. And then we also have perinatal audits in which whenever there's a death, in a neonatal death or perinatal death, it is audited. And a team which has a higher cadre of staff, maybe an obstetrician, a pediatrician, actually goes to that facility to audit the death. But some of the challenges we have with this is that it is not exhaustive enough on the sick newborn parameters and the small newborn parameters. One of the issues is that there are not enough parameters on kangaroo mother care, etc. within this DIN. So that's a challenge. Next slide, please. The fifth standard that we have has to do with the availability of the competent health workforce. And that ties in with WHO standard 7. So Ghana has the Ghana College of Nurses and Midwives, and now they train nurses in neonatal care. So within the country, you don't need to go abroad to go and train in caring for newborns. And we also have the Ghana College of Physicians and Surgeons, which trains pediatricians. But then, even though these colleges are there, you still realize that there is a gap, because after they are trained, most people like to stay within the city centers, and therefore they do not want to go to the hinterland where the need may be high. So that distribution of the workforce still is a challenge, and we still need more specialized workforce. For instance, we have just 2 pediatric intensive care units and doctors. So if you have a really ill, tiny little baby and you can't get a neonatologist, they could help you, but we have very few of them. We have very few of the neonatologists also. But I should mention that aside these colleges, there is training for tutors of midwifery institutions on helping babies breathe, essential care for every newborn, so that they can incorporate it into the syllabus that they teach their students. Some of the medical schools have also incorporated helping babies breathe, resuscitation of the newborn, as an examination station. So if you don't pass that examination station, you fail the exam. Next slide, please. Then our strategy number 6 has to do with compassionate care, and that ties in with the WHO standards of 4, 5, and then 6. So there's training of the workforce going on, but then we have a challenge: the cultural norms about the newborn, the perceptions, the beliefs. People still believe the newborn is disposable. We shouldn't invest so much in the care of the newborn. So that's the major challenge, and some way, somehow, it creeps into the health force. So even with the healthcare workers, sometimes when there's a newborn death, they are not as disturbed as when there's a maternal mortality. And it all has to do with the cultural norms that we have grown up with. And that's quite a bit of a challenge. Next slide, please. Our standard strategy number 7 has to deal with availability of the drugs, equipment, etc. So in the country, we have created a lot of newborn corners. Throughout the MEPC period, many hospitals created newborn corners. And some facilities have even included newborn commodities into their peer review. So if you're coming to assess your hospital and you don't have a newborn care area, you don't have drugs for the newborn, it goes against you. But then that is not a national thing yet. It is some regions that have done that. But we still have major challenges when it comes to insurance payments and then suppliers. Health insurance doesn't pay for every single thing for every newborn. And that is a challenge. And sometimes you can't get suppliers to give you certain commodities. For instance, it's difficult getting suppliers to even give you the neonatales that are used for training of HBB and essential care for every baby. Next slide, please. So our strategies number 8 to 10 fit in with the overall picture about strengthening community engagement involving the public sector and the private sector, and then strengthening appropriate research. One of the things that we found out during the previous strategy was that the private sector was left out. So you have all these private hospitals that are virtually doing their own thing. So in this new strategy, we want to work on involving the private sector as well. And then strengthening appropriate research. A lot of research is going on with some partner institutions to be able to generate data that we can use to make decisions. Next slide. So this is my last slide. So what has helped us with our challenges is the high level of commitment, the newborn subcommittee that answers to the highest level of the healthcare service. That has really helped. And then advocacy. We've generated quite a lot of interest in newborn issues. And this advocacy is also leading to some of the public now desiring an increased level of quality of care. And one of the things that we need to continue doing is using a multi-sectoral approach. If you have a wonderful facility, but the road leading there is poor, you're not going to be able to achieve anything. So multi-sectoral approach to be able to reduce our newborn deaths will help us a lot with the care of the sick and small newborn, because we know that for us in Ghana, our newborns die from birth asphyxia, prematurity, and infections. Thank you very much.
Thank you so much, Dr. Thank you so much, Dr. Muruti, for Dr. Adoma, for your presentation. And just so you know, there are a slew of questions already coming in for you. So we will make sure to share those. And I look forward to the discussion that's going to ensue as we try to answer all those questions. And so just to keep us on time, and thanks also for sticking to the time allocated to you. So for now, I will introduce our last but not least a panelist who comes from WHO Afro. Dr. Assumpta Muruthi is a pediatrician by profession. She's a medical officer working with WHO at the Regional Office for Africa as the newborn health focal person. And she brings extensive experience in working with countries on adoption, adaptation, and implementation of guidelines for newborn health through policy dialogue and technical support. Dr. Muruthi, over to you.
Thank you very much. And thank you to our two presenters, Dr. Adama and Dr. Coulibaly, who have really shared a lot on what is happening in countries. And that is kind of a summary of what most of the African countries are doing. They have adopted a lot of the guidelines that have been put out there. They are doing all efforts to build capacity and do what they can do. So I thought we can go to the next level, because now what we are trying to look at is the quality that we are putting in the implementation of whatever it is that is happening at countries. And we find that quality is the next level that we need to focus on so that we can improve on the implementation of the packages that we are doing. And as a background, we see the number of babies of newborns that die globally. And at the same time, the number of stillbirths that are also part of that. So in 50-50, 2.5 million newborn deaths and 2 million stillbirths. But the second bullet is more important. 30 million small and sick newborns require access to quality care. And when you look at the quality, the level of quality that we are talking about, in developed countries, we are talking about 1 in 10 patients being harmed by whatever is happening to them in the healthcare facility. So you can imagine what is happening in our region. And looking at the basics that we need to have, and they are not there, like lack of running water. We can see 40% of health facilities in our region don't have running water. Nearly 20% of care, there's no sanitation. And especially the running water has come to force with the COVID context, because that is one thing that has come out as very, very needy. The other aspect that we need to look at is the abuse and lack of respect including for the small and sick newborn. So, and this leads to a lot of harmful, practices going on for this. Next. Next. So when we look at what we are supposed to do for these cohorts, and especially that which pertains to the small and newborn, the issue of antenatal care, the coverage of the packages that are there is wanting. We still have a lot of work to do, even as we are setting out standards that we need to operate on. If you look at skilled attendance, which is supposed to be a major platform for our newborns, especially the small ones and preterms, our coverage in the region is only at 59%. And of course, institutional delivery, where we can capture some of these babies and be able to attend to them immediately, it's still at around 56. Then of course, cesarean section is not available in many areas when it is needed. And postnatal care is still far from what it should be. Not to forget breastfeeding, which is very important for our cohorts of discussion this evening. Next. Next. So to further focus on what we need to do, please go back. WHO came out with please go back. Yeah, a vision on how we could improve quality of care. And the vision is to have every woman, newborn, child, and adolescent receive quality healthcare services throughout their life cycle. And next, when we set out the strategies for this vision, most of the countries that adopted it are supposed to see how they can do deliberate work to reduce the deaths. We have heard from Ghana, we have heard from Malawi, a lot of work is, from Mali, a lot of work is going on to try and see how best you can address the needs of these small and sick newborns. When you look at how we are supposed to implement it, we go along the continuum of care, and that was reflected in the coverage of the packages that are there. That we start with adolescent, prepare them properly, then pregnancy, what we need to do, and when the newborns come, what do we do? And postnatal care for them. Next. Next. Are we going backwards? Next. Yeah. Next. Next. So to implement the vision, this WHO and partners have come out with standards, and these are to help in accountability. And Ghana very, very ably went through what they have done and how they have addressed each of the standards that comes out. Now, these standards are supposed to guide countries on how to go about it. We have seen how Ghana has applied every bit of it, from leadership to policies to implementation to investment and involvement of the community. Next. And in the previous slide, we have 3 standards, one for maternal and newborn, which has some standards for newborn, then one for children, again, which incorporates some of the newborn standards, and lately the small and sick newborn standards, which give guidance on how to engage countries on that. So for the standards of sick and small newborn, they define the standardized and mainstream inpatient care of small and sick newborn, building onto what we already have. And we've had all the countries are doing essential newborn care. So they are supposed to guide countries in caring for this vulnerable population and support quality of care for them within the universal health coverage. And this is inconsistent with the quality of care framework. Next. Next. So the standard framework looks at health systems, both provision and then the care itself, both provision and experience of care. And every standard is addresses, or rather, there are standards that address all these elements. They are applicable to health facilities offering maternity and newborn care. They cover essential packages for newborn. There is the focus on newborn, and also it's family-centered and specific for priority and thematic areas identified under the 8 standards. Next. So here, these are the 8 domains of the standards. So provision of care standards. There's provision of care standards. There is experience of care standards and health systems resources. And there are 8 in total. I think we'll share this presentation and you can look further into this. So when we look at the total care of the newborn, we need to take care of each and every aspect of the standard. And like Ghana clearly outlined, they went through leadership up to the involvement of the community and have very, very ably been able to internalize these standards within their health systems and the care for small and sick newborn. Next. 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 So in summary, there's a lot to be done. Countries are doing something, but we need to contextualize them within the standards that have already been brought out so that we can be accountable and we'll be able to measure for each standard, because it goes from care to involvement of the caregiver, the health workforce, and the community, and everybody becomes accountable in one way or other, and it can be measured using the standards. So thank you very much.
Thank you so much, Dr. Muruthi, for your commentary and also for sharing those standards. And thanks for setting the stage by showing us how both countries have made progress in putting in place a system that allows them to address and take care of the small and sick newborns, starting from what they're doing at the, for all newborns through essential newborn care, and then starting to look at specific care for the small and sick newborn. I will shift to the questions, and hopefully we can get to all the questions that have been asked, mainly for the 2 country presenters, Mali and Ghana. For ease, I will try and tackle the questions that were asked of Dr. Coulibaly in French. There will be translation, and then I'll shift over to the questions for Ghana. And there are some questions that will actually be asked to both, and we'll see how we can manage that. So for now, I will shift over to French. Dr. Coulibaly, merci beaucoup. Il y a eu beaucoup d'intérêt dans votre présentation et j'ai quelques questions que je vais essayer de regrouper en 3 thèmes pour faciliter les réponses. Donc, la première question, c'était par rapport à la pratique des soins mère kangourou. Ce que les gens voulaient, il y a une question qui demande si les mères qui pratiquent, si ça se fait uniquement dans les établissements ou si cela continue ou même si ça commence au niveau de la communauté. Donc, en fait, quelle est la pratique des soins mère kangourou pour les petits points de naissance? Est-ce que c'est uniquement au niveau des structures sanitaires ou est-ce qu'il y a une continuation au niveau du domicile et dans la communauté? Ça, c'est la première question. Et la deuxième question, commencer par cette question-là, en fait. Oui. Vous pouvez vous enlever, vous êtes sur mute. On ne vous entend pas. Vous avez votre micro est muté. Voilà, allez-y.
Merci beaucoup pour la personne qui a posé cette question. Pour la pratique des soins mère kangourou, ça commence au niveau des structures de santé. Mais une fois que le nouveau-né n'a plus de problème de santé et que c'est surtout la prématurité, et seulement là, la maman et une autre personne de la famille est initiée aux soins mère kangourou. Et au niveau des différents paramètres à surveiller chez l'enfant, la personne on enseigne ça aux membres de la famille et on les laisse partir à la maison pour continuer les soins mère kangourou. mais la personne retourne de façon régulière pour des visites de routine et de suivi. Je vous remercie.
Merci bien. Et l'autre question, en fait, a trait aussi à cela, c'est, donc, vous nous avez expliqué ce qui se passe après la sortie pour le petit et pour les enfants malades. Les autres, parce que comme le thème, c'est l'enfant petit et l'enfant malade, est-ce qu'il y a un suivi après la sortie de nouveau-nés? Et peut-être que cette question voulait demander aussi, est-ce qu'il y a un suivi au niveau du ménage, par exemple, au niveau communautaire? Est-ce qu'il y a une structure qui permet de suivre les malades au niveau de la communauté ou du domicile?
Ok, merci. Par rapport au suivi de l'enfant malade, le suivi est fait par le système des rendez-vous. L'enfant malade, une fois que son état le permet, il est exerté, c'est-à-dire on le libère, il rentre à la maison, mais avec des rendez-vous de suivi. Donc, vous ramenez l'enfant à tel rythme, par exemple, une semaine après ou bien 3 jours après, une semaine après. Il y a un rythme de suivi en fonction de chaque cas et chaque maladie qu'on donne à la maman, en fait, la personne qui accompagne l'enfant. Le suivi est fait ainsi. Et par rapport également au niveau de la communauté, nous avons dit qu'il y a des soins essentiels à la communauté où les ASC passent de maison en maison, font des visites à domicile. Elles ont déjà enregistré les femmes qui ont accouché et les femmes qui sont enceintes. Et les visites à domicile sont faites. Et lors de ces visites, on voit s'il y a l'enfant, est-ce que l'enfant était malade ou bien l'enfant présente des signes de danger. Est-ce que l'enfant a un petit poids de naissance? Et vous étiez hospitalisé, vous êtes revenu, est-ce qu'on vous a donné des rendez-vous? C'est juste pour donner des conseils et orienter cet enfant, si le besoin de consulter ou de suivi est là, vers les structures de santé, c'est-à-dire les SESCOM, qui est la structure de santé la plus proche de la communauté.
Merci, Dr Coulibaly. Donc, en fait, le Mali a mis en place, la structure que le Mali a mis en place à travers les ASC permet aussi de faire un suivi une fois que la mère, le nouveau-né sont sortis.
Tout à fait.
Merci. Merci bien. Il y a une troisième question, toujours par rapport, et ceci concerne en fait l'issue parmi les petits points de naissance gérés par le SMK. Ça, c'est une question de Sanoussi du Niger, avec les plus de 19 000 petits points de naissance qui ont été pris en charge. Quelle est la proportion? Est-ce que vous avez une idée de la proportion de décès qui ont été enregistrés parmi ces petits points de naissance? Et si au-delà de ces décès, est-ce que vous avez aussi une idée des causes, causes principales de décès? Donc, en fait, c'est parmi le suivi de 19 000 qui ont été enregistrés à travers le programme que vous avez cité. Et c'est peut-être la question peut-être, c'est de donner en général, est-ce qu'au Mali, vous avez un système qui vous permet de regarder l'issue de petits points de naissance et s'il y a décès, de déterminer les causes de décès?
Au Mali, il y a un système qui permet de suivi. Je vous l'ai dit que quand l'enfant doit rentrer à la maison, l'enfant rentre à la maison avec un calendrier de suivi. Et si c'est avec le contact de l'enfant est pris au niveau de la structure de santé. Et si la maman ou le parent respecte ce calendrier de suivi, le suivi est fait au niveau de la structure de santé. Et il y a un autre système au niveau des ASC qui permet de récupérer ces enfants. Lorsque l'ASC passe en visite en domicile, il va voir un enfant qui est là, il pose des questions, l'enfant était hospitalisé, ou bien il voit en fonction des signes que l'enfant présente.
Docteur Coulibaly, je vous interromps parce que comme on a beaucoup de questions, en fait, ici, ce n'est pas par rapport au suivi. La personne demandait comment est-ce que vous, pour les décès, c'est par rapport au décès,
Oui,
quel a été le taux de décès et quelles sont les causes de décès? Désolée de vous orienter par rapport à la question.
Okay,
voilà.
OK. Par rapport au décès, les données que je vous ai données, ça, c'est les données que le projet SSGI, le service de santé à grand impact, a produit par rapport à un projet sur SMK. Et là, ils n'ont pas fourni les données sur les décès maternels, sinon ces données ne sont pas disponibles. Mais au niveau des hôpitaux, Ces données sont disponibles. Quand on passe au niveau de la structure soins mères kangourous qui ont pris en charge ces cas, on va trouver ces données, mais présentement, une séance tenante, je ne les ai pas.
OK.
C'est juste ce que je peux dire à la personne.
Merci bien. Je vois que Dr Fatoumata Traoré, qui était sur le projet, est présente. Fatoumata, est-ce que tu peux brièvement nous donner une réponse à cette question? Et après, je vais shifter vers les questions du Ghana. Fatoumata, si tu n'as pas la réponse, je te laisse préparer.
OK, bonjour tout le monde.
Bonjour Fatoumata.
Vous m'entendez?
Oui, on t'entend
bon,
très bien.
En fait, le système DHS2 qui est mis en place au Mali ne permet pas d'identifier, de chiffrer les nombres le taux de décès par rapport lié au petit poids de naissance de façon spécifique. Mais au cours de notre exercice, on s'est amusé à calculer à quelques moments et on est autour de, dans certaines structures, on est autour de 8 à 12%. Mais on ne peut pas l'extrapoler à tout le Mali parce que le DHS2 ne nous permet pas vraiment de quantifier ça. D'ailleurs, c'est une question qu'on va mettre en profit pour améliorer notre système d'information sanitaire parce que c'est bien normal de pouvoir quantifier ces décès. Mais par rapport aux causes, en général, ce sont des infections liées aux fausses routes. Parce que si le réflexe de déglutition, de scission et de déglutition n'est pas coordonné et que les mamans ne font pas attention, l'enfant en s'alimentant peut faire fausse route et ça peut entraîner une infection pulmonaire dans les 2 ou 3 semaines, dans les premières semaines de la vie. En général, c'est ce qu'on constate. La cause est liée généralement à l'infection. Et plus tard, en général, quand il dépasse le premier âge, en général, ce sont des enfants, s'ils ne suivent pas bien, ils tombent dans un tableau de malnutrition. Ça trouve qu'ils ont quitté l'âge de nouveau-né.
Merci, Fatoumata. Et peut-être que, and maybe I'll say this in English. I'm going to shift in English. Thank you so much. And I think the last question that was asked of Dr. Coulibaly is one that I think in general, the community of practice should be talking about, which was the safety of oxygen in use in small babies. The issue around the proportion of deaths among small newborns that are taken care of using KMC is that the perinatal or the death audits for newborns are not conducted in the same way as they are done for maternal deaths, and that's something that I am aware of. That is an issue in most countries. The proportion of deaths that are analyzed very often is less than, and we know that you cannot get through all of them, but at least getting a proportion of them done would be useful, and that was something that we struggled to get done in the Mali context. And I know that that's something that the country is working to improve capacity of conducting perinatal death audits. With that, I would like to shift over to Dr. Adoma because we do have a number of questions for her. And I will regroup them by themes. The first one, which should be a quick one, was where the newborn subcommittee is based. That was a question from Dr. Assunta. Maybe you could answer that question in Arabic. Yeah.
So the newborn so the country is divided into regions, and each region has a newborn focal person. So these regional focal people come together with some key other stakeholders from the Ministry of Health, and then they are all parts of the newborn subcommittee. So it's not held at the regional level, but it's a national thing. But when they meet, they go back into the regions and then they get the work done.
Thank you. The second question was around referrals, and there were 2 of them. And so I'll start with the easier one, which is how does the referral happen? Very often we know that in some cases the newborn may not even be the small sick newborn may not be transferred with her mother. We hope that they are transferred together because you are applying the standards of care. But the other question was, so does the referral have a trained profession provider? that is included in the referral during transportation? So that was the first question. And then the second question is there a regionalized plan for referrals that's based on the service that's needed, not just geographic, but that's based on the service that's needed? Maybe you could answer both questions together. Thank you.
Okay, so when the babies are being transferred with the ambulance, the emergency medical technicians who have had some level of training, but not enough, they are normally in the ambulances and then they accompany the newborns. But for many of us pediatricians, we prefer to go ourselves with the baby, or to let somebody who's really able to resuscitate the baby go with the baby. But in other communities too, a healthcare worker, a midwife, or a community health nurse will accompany the baby as they are going, as much as is possible. But then sometimes they are not able to because they are just too on duty and new labor cases are coming in. So it's a whole range of different options. Now about the regional, the referral system. So the country is divided, like I said, into the regions and then into the districts and then into the communities. So the community will refer to the district hospital, the health center will refer to the district hospital. If the district hospital is not able to manage, they will refer to the regional hospital. And if they are not able to manage, they will refer to the teaching hospital. But sometimes you have some cases in which maybe at the district hospital, they know that this patient cannot be managed at the regional hospital. Then they will send straight to the teaching hospital, which is not now through the regional referral system. So even though the guidelines...
We have briefly lost her. Dr. Adoma? Is everyone else still on the, I just want to make sure that I'm not the only one who's off.
Yes, I'm here.
Oh, okay, there you are. Dr. Adoma, please, we had lost you briefly.
No, it's Assumpta. Okay, she's back.
Yeah, she's back. Yeah. Dr. Adoma, please go ahead. We had lost you right in the midst of your response to the regional plan. I don't know where we...
Oh, sorry.
Maybe you can wrap that, yeah.
Okay, so let me just summarize that again. So even though normally the referral should go from the community or the health center to the district hospital, to the regional hospital, then to the teaching hospital, you may have somebody at the district hospital who realizes that this baby with the exomphalos cannot be managed in the regional hospital because there's no pediatric surgeon. Therefore, they'll refer straight to the teaching hospital. So though the policy goes through that hierarchy, it doesn't always happen like that in real life.
And I guess that's the way of going around the based on need. And hopefully we know that compliance with referrals can be an issue for families, and mainly because of financial reasons. And maybe that allows us to shift to the question around finances. This was a question from Kumar. We know that you mentioned insurance doesn't cover everything. So what options are there for financial protection that have been tested and worked well in Ghana to increase access?
Okay, so that's a difficult one. Finances is...
Hello? Unfortunately, we keep on losing. I would have wanted to ask the same question of Mali as well.
MTN, okay. So MTN, they are a telecommunication company. The First Lady she built a huge center for Konfanochi, which is one of the teaching hospitals, a huge center for the neonates. So the private sector has been very important. And on the ground, certain individuals in their facilities get a sick kids fund. They get a fund for such children. So they approach prominent people and ask them to donate into that fund. So when there's a baby who really needs referral, who needs certain drugs that is not covered by health insurance, or the quality of drug is not covered by health insurance, then they fall on this fund. So it's mainly not a national thing, but an individual thing that people do to get the patients moving and to get the babies well.
Thank you so much. And if it's okay, I think the audience would be interested in hearing whether there is any financial protection for the Mali. So I'll ask the same question of Mali, even though it was only directed, and maybe the question was directed to just you, but I'm interested in hearing what's happening in Mali. Dr. Coulibaly, nous savons que les finances sont souvent une barrière pour permettre aux familles.
Système de référence évacuation au Mali.
Non, c'est par rapport aux finances, en fait, protection financière pour les familles. Nous savons que souvent les finances c'est une barrière pour permettre aux familles d'accéder aux soins. Est-ce qu'au Mali, il y a une protection financière qui a été testée, qui est en place pour permettre aux familles d'accéder aux soins quand ils en ont besoin? Ça, c'est la question. En fait, elle a été posée au Ghana, mais ce serait intéressant de savoir quelle est la situation au Mali.
Bon, au Mali, je dirais, il n'y a pas quand même un truc bien structuré par rapport à la protection financière. Et c'est laissé à la charge de chaque famille. Mais il y a quand même un système de gratuité que j'ai annoncé par rapport à la prise en charge de certaines pathologies, surtout pour les enfants. Donc, ce système existe par rapport à la prise en charge du palu qui est gratuite et la vaccination qui est gratuite pour les antigènes du programme élargi de vaccination et le PTMI, la prévention de transmission mère-enfant est gratuite. En dehors de ça, il n'y a pas un autre système bien structuré qui prend en charge les nouveau-nés.
Donc, ça veut dire que les nouveau-nés petits ou les nouveau-nés malades pourraient ne pas être protégés. Ça, c'est un défi pour le pays.
Tout à fait.
OK, merci bien.
Ceux qui ont un système d'assurance maladie qui couvre leur famille, il y a ça aussi.
Oui, ça, ce sera probablement au milieu urbain, mais en milieu rural, on peut s'imaginer que ça n'existe pas. Exactement.
Ça n'existe presque pas.
OK, merci bien. The next question is for Dr. Adoma, which is around coordination in training. So is there a coordination in training curricula, both didactic and competency for newborns between GCMN and GCPS? That was a very specific question for you.
Yes.
And maybe you can explain how it works.
Okay, so currently with the Ghana College of Midwives and Nurses, what they do for those who are doing pediatrics or neonatology is that after they do their classroom work, etc., and they come to the ward, they are attached to a pediatrician. So they actually work hand in hand together with the pediatrician and then pick up skills. They have two programs. One is the associate, which is I think 1 year, and then the membership, which is 3 years. So the associates, they do a lot of classroom work, learn a lot of theory, etc. And some pediatricians even teach them. But the practical work, they really are only going where there's a pediatrician. So they learn directly from the pediatrician through a direct mentorship. Yes, and I just wanted to add one thing to the funding issue. And that is that we are considering that the private sector has a lot of money and there's a lot that they can do to offer the small and sick newborn, setting up newborn facilities, buying us incubators, radiant warmers, etc. So is it possible that, as is done in other countries with government, there can be some sort of tax relief if you donate some certain amount of money towards newborns? It's one area that if we are able to look at, maybe we'll be able to get a lot of money to support the newborns without it necessarily coming from governments alone.
Definitely, and thanks for that suggestion. And I can imagine that if there are any participants who have tested those approaches in their countries, that they might be able to share this as part of the community of practice. Definitely interested in that. I will, so there was one more question around safety, and I wanted to address them concurrently, which is, and I think it's more of an issue for all of us, it's the safety as we see increasing use of oxygen in small babies, to ensure that, and Dr. Muruthi, are there any standards that take that into account? Because I can't imagine that's similar to what we see in more developed, more resourced countries, that this is an issue, and it would be interesting to hear whether from either of the presenters, Dr. Coulibaly, I hope the question is being translated for her, and Dr. Adoma, what measures are in place to ensure the safe use of oxygen? And then the other one I'll shift to it briefly, which is one that we can have more discussion around, which is the safety of chlorhexidine for cord care, as we can see increasing use and the reported misuse that was shared by Dr. Coulibaly. But maybe the first question, and I was asked not to, but I would jump to French here. Dr. Coulibaly, la question a été: quelles sont les mesures de sûreté pour l'utilisation de l'oxygène parmi les petits poids de naissance pour éviter les complications? Comme vous connaissez, les complications liées à l'utilisation non régulée d'oxygène parmi peut avoir des conséquences néfastes qui sont permanentes. Est-ce que vous connaissez? Est-ce qu'il y a des mesures en place pour assurer l'utilisation sauve? Donc, en fait, des paramètres et des protocoles pour éviter ces complications ou gérer les complications. Si vous pouviez répondre brièvement.
Par rapport aux complications liées à l'oxygénothérapie,
oui,
nous avons les formations qui ont été faites. Ça a commencé par les formations des prestataires et il y a le système de coaching mentorat des formateurs et il y a l'existence des protocoles de prise en charge. Lorsqu'il y a oxygénothérapie, les différentes étapes sont décrites et le personnel a le pouvoir de le consulter avant de faire la prestation. Donc, je pense qu'avec tous ces outils et la sécurité, on peut dire que même si elle n'est pas garantie à 100%, quand même, elle est quand même prise en compte. Également, les mentors qui sont là à côté pour surveiller les prestations de soins.
Et l'équipement, est-ce qu'au point de vue équipement, est-ce qu'il y a un équipement, par exemple, un oxymètre pour suivre le taux d'oxygène? Est-ce que l'infrastructure existe en fait? Et à quel niveau est-ce que cette infrastructure se trouve? À quel niveau du système?
Au niveau des services de néonatologie qui se trouvent dans les hôpitaux, les CHU et les districts sanitaires, c'est-à-dire les centres de santé de référence, qui sont les centres de santé de deuxième niveau de référence. Donc, l'oxymètre de pouls, il n'était pas présent, il n'est pas fait systématiquement. C'est dans le cadre d'un projet, le projet R. Il y a plusieurs projets qui sont en train de faire la formation. Ça vient juste de commencer en 2020. Les formations sont en cours et les dotations des centres pilotes également sont en cours. C'est après cette phase pilote qu'on va aller à l'extension de l'oxymètre de pouls. On est juste à cette phase.
OK, donc en fait, on est tout au début. On est tout au début.
Tout au début.
OK. Merci bien, Dr. Coulibaly. With that,
à la chlorhexidine, par rapport à la chlorhexidine, on dit
la
sécurité.
Oui, allez-y, je vous laisse.
Parce que j'avais une deuxième question relative à la chlorhexidine.
Par rapport à la chlorhexidine, je crois que c'était plus un commentaire. Donc, et je vous remercie. Je crois que par rapport à la chlorhexidine, le commentaire, c'était qu'il était temps de commencer, c'était une suggestion du docteur Indira qui disait peut-être qu'il serait temps qu'on commence à regarder la question de l'utilisation de la chlorhexidine parmi les petits poids de naissance. Donc, en fait, avec ça, parce que je sais qu'il me reste 1 minute, on va nous couper, je vais faire un sommaire. So, thank you so much. I would like to thank everyone. There are a couple of questions we didn't get to, and I know that we will make sure that those questions get answered because I think with the last minute that I have here, it's going to be hard to have our presenters get through them. But I just want to promise that we will make sure that both questions get tackled. I would like to first, maybe ask everyone to join me in thanking our presenters for their excellent presentations and for their responses to the questions that were asked for them. It was, it's exciting to see the progress that has been made in countries in terms of putting systems in place that taking care of small sick newborns. It's also exciting to see that we are doing this not just at the national level in large facilities, but that this care extends all the way to communities where most of these babies are probably going to be discharged to. And then for Dr. Muruthi, thanks for sharing those standards of care. I'm hopeful that these get widely shared. We will make sure that to have all the resources shared as part of the committee of practice. And I would encourage that we continue the conversation there, as well as sharing, best practices that are emerging and the challenges, so that where we have participants that have put systems in place, that those can be shared there as well. And thanks to the team for having set this up. I hope you all have a good day and good evening to those who are getting to the end of their day. Thank you.
Thank you, Winnie.
Thank you.
Merci professeur. Au revoir tout le monde.
Merci. Winnie,
bye. Oui, ça va très bien. Bye bye everyone. And pour ceux qui sont encore là, for those of you who are still around, please, there is a last slide on joining the community of practice. We invite you to join it because I think there's much more taking place there. So thank you everyone and have a great day. Thank you.
Thank you. Yes.
Bye.
La chose que j'ai retenue, qui sont plus des stratégies, il y a des choses intéressantes. Si tu peux